Hello, dear students. This is a small class on male partner in infertility, how to go about with the evaluation. You are asked such questions in the NEET PG exams, the INICET and NEET PG and even FMGE. What are we going to be talking about in this class are these four things: male reproductive system, a little bit on the anatomy, not the detailed anatomy, and a lot on physiology, etiologies of male infertility, how to evaluate, and then management will be discussed in a different class. The male reproductive system, do you know that this is the testis? And this is the place where spermatogenesis happens. Then we'll see about a little bit about the histology of testis. From the testis, the spermatozoa travel to the epididymis where they undergo maturation. And from the epididymis, they go to the vas deferens. So this is vas deferens. And its function is to transport spermatozoa. So a lot of spermatozoa with a little bit of semen goes through the vas deferens to the ejaculatory duct. This is a structural representation of the seminal vesicle. And seminal vesicle is like this: seminal vesicle, and the vas deferens comes, and the seminal vesicle joins it. And what forms after the joining of these two, vas deferens and the duct of seminal vesicle, is called the ejaculatory duct. And the ejaculatory duct opens into the urethra. Here, prostatic secretions will enter into the urethra. So semen is the fluid along with spermatozoa. So it's like plasma with spermatozoa. The semen, the fluid of the semen is contributed majorly by the seminal vesicles, little bit by the prostate, and spermatozoa come from the testis. And at the time of ejaculation, this valve, because it is going to come out from the urethra, the common opening for both semen and for urine. So at the time of ejaculation, the bladder neck closes so that this semen doesn't go back into the bladder and urine doesn't leak during ejaculation. And then there is ejaculation, and these spermatozoa carry male genetic material, male DNA, to the female, to the oocyte for fertilization. Right? That was just a very superficial overview. This is what I just explained. Testis is this, where spermatogenesis is going on, which is a meiotic division. That undergoes in the seminiferous tubules in the testis. And then epididymis, and then vas deferens. And then seminal vesicles, ejaculatory duct. Now, seminal vesicle, how does it add to the semen? Volume of the semen. Semen pH, alkaline. The secretion of seminal vesicle is alkaline. Why is this important? Because if there is something has to happen to the seminal vesicle, the pH of semen will fall. It also secretes prostaglandins, and then there is the ejaculatory duct. Sometimes this gets obstructed. That also has similar presentation of low volume semen. So anything that is affecting this part, semen volume will decrease because semen volume comes from seminal vesicles, and pH will decrease because alkalinity also comes from the seminal vesicles, ejaculatory duct, and then prostate, which also adds to semen and a few secretions like citric acid, acid phosphatase. So prostatic secretions will make it more acidic. But majorly, since seminal vesicles is the major contributor, the pH is low. And urethra is again for sperm transport. Now, this is a picture of the internet. This is the testicle being explained in a better way. These are seminiferous tubules. The seminiferous tubules join to form what is called retitestis. These are efferent ductules which go to the head of the epididymis, caput of the epididymis. And from there, this is the chorda of the epididymis, the tail. From the tail of the epididymis, the vas deferens begins. This is the vas deferens. There is one condition where vas deferens is absent congenitally, bilaterally. That is called CBAVD. Congenital bilateral absence of vas deferens. It is seen in cystic fibrosis. Now, this is also an interesting topic for NEET PG exams. You have to know what else happens in cystic fibrosis. Again, that's a topic of different class. We'll discuss it in different class. So where were we? First, the male anatomy, and then we saw the testicular histology just a little. Now we'll take a cross section of one of the seminiferous tubules and we'll see what goes on inside. So this is that tubule. You see this, what is the color? What would you call it? Purple, indigo, whatever. This that I'm outlining here is a Sertoli cell. The function of Sertoli cell is to support spermatogenesis. These are spermatids undergoing First mitotic division and then meiotic divisions to form spermatozoa. The spermatozoa will be released into the lumen of these seminiferous tubules, and from the lumen they'll reach the epididymis to be transported via vas deferens. So Sertoli cells support spermatogenesis. Spermatogenesis is this, from round simple cells, somatic looking like cells, to germ cells that are specialized. The spermatocyte to this kind of spermatocyte, that is called spermatogenesis. That happens in the seminiferous tubules. And outside the tubule, this is also called the blood testis barrier. Outside the tubule, there is this cell called Leydig cell. What hormone does Leydig cell secrete? It secretes testosterone. So it secretes testosterone, which does cross the blood testis barrier and goes inside and supports spermatogenesis. So spermatogenesis requires testosterone. It requires the presence of Sertoli cells. Leydig cells secrete testosterone. What is the stimulus for secretion of testosterone? Why do Leydig cells secrete testosterone? We'll see that also. Sertoli cells support spermatogenesis, as we saw. Leydig cells secrete testosterone. Now, Leydig FSH acts on Sertoli cells to aid spermatogenesis, and I was asking you, Leydig cells secrete testosterone under the influence of what? LH. So coming back to this slide, Leydig cells are going to secrete testosterone, and what is the stimulus for it? LH. And what supports the Sertoli cells to support spermatogenesis is FSH. These are all products of which gland? The pituitary gland. Anterior or posterior? It is the anterior pituitary. You should also know what are the hormones secreted by the posterior pituitary. For PG exams, you're supposed to know everything of every subject. So Sertoli cell supports spermatogenesis, Leydig cells secrete testosterone, the two cells that we saw in the seminiferous tubule. And then these are blood vessels. Blood vessels are not there inside the seminiferous tubules because they have to maintain a blood testis barrier. Because the genetic makeup of the spermatozoa is slightly different, and there can be reactions. There can be antibodies developing to spermatozoa because it is haploid. The other somatic cells are diploid. Now, hypothalamus in the brain secretes GnRH. This is similar to, in part, it is similar to female physiology, but there are differences also, which you need to understand in this class. So hypothalamus secretes GnRH, same as in females. GnRH then acts on the anterior pituitary gonadotrophs. Gonadotrophs are those cells of anterior pituitary which secrete LH and FSH. So under the stimulus of GnRH, gonadotrophs, the cells of anterior pituitary will secrete LH and FSH. LH is luteinizing hormone, FSH is follicle stimulating hormone. The names have come from female physiology, but they have functions in male reproductive system as well. LH acts on Leydig cells to secrete testosterone. FSH acts on Sertoli cells for support of spermatogenesis. So we need all of this for spermatogenesis. These will act on the gonads, and the gonads will synthesize sex hormones. Which sex hormone is there in the males? It is testosterone. And if testosterone is low, what will happen now? Suppose there's some injury to the testicle and the testicle is not secreting enough testosterone. So if testosterone is low, there'll be a feedback received by the pituitary and the hypothalamus that systemic testosterone is low, and then they will start increasing the secretion of FSH and LH just like in females. That physiology is there. If the systemic testosterone level in blood is high, FSH will be low. If testosterone level in blood is low, FSH, LH will rise. This is a very, very important concept to understand a few pathologies. So the Sertoli cells secrete 50 other proteins, out of which androgen binding protein is important. Leydig cells secrete what? Testosterone. Sertoli cells secrete what? We don't know. A lot of substances, out of which androgen binding protein is important. Why is androgen binding protein important? Because this is secreting testosterone. Testosterone is going inside as well as it is going into the bloodstream. But we are not bothered about bloodstream testosterone. We want excess of testosterone inside the seminiferous tubules. So ABP is that protein which concentrates testosterone into the seminiferous tubules. That is why if someone has testosterone deficiency, as in they have hypogonadotropic hypogonadism, their FSH LH is not there, or they have some Leydig cell problem, And if you give testosterone systemically, if you give testosterone injection to them, it will not help in their spermatogenesis. Somebody has azoospermia and you see that the testosterone level is very low. Will giving testosterone help? It will not help, because what you need to do is what needs to happen in the body is the seminiferous tubules have to concentrate the testosterone. So what kind of testosterone is required for spermatogenesis? Testicular testosterone. Who concentrates the testicular testosterone? Androgen binding protein. So when you give exogenous testosterone, it does not improve the fertility of the male. On the contrary, it decreases the fertility of the male, which is very interesting and important. What happens is you give testosterone. A lot of this is a common reason for infertility in people who go to gym and who take steroids, anabolic steroids. They have androgenic effect. So what this does is the blood androgen levels, testosterone levels, they rise. If you inject testosterone to someone, their blood testosterone will rise, and that will act on the hypothalamus and pituitary. That will act on hypothalamus pituitary to cause decrease in LH and FSH. If LH and FSH is decreasing, Sertoli cell will not be supported by FSH. Leydig cell will not be supported by LH. Intratesticular testosterone synthesis is actually decreasing, and testosterone is not getting concentrated in the seminiferous tubules. And that is why the person may land in azoospermia when you give testosterone to a male. So systemic testosterone does not help in azoospermia. It is a cause of azoospermia. So if you know such small things, it helps in the history and also to answer a few questions in exams. Did you understand that? So if you are thorough with female physiology, female reproductive physiology, there are a few changes here and there in male reproductive physiology. Now, this principle is similar to when we give estrogen. So when I was in third year, it was quite surprising for me to know that these sex hormones, the estrogen and progesterone, are the ones which are making her infertile when you give it in the form of OC pills because of the feedback. So that is what is exactly happening here. You give testosterone, the person becomes sterile. We don't use it for contraception because it has all other side effects also. Similarly, when we give estrogen, progesterone, the female becomes sterile or infertile for that period of time because she doesn't ovulate. Same principle. You give exogenous testosterone, the person will not remain fertile if you give it for a long time. Androgen binding protein concentrates testosterone within the seminiferous tubule. So intratesticular testosterone is important. High testicular testosterone is required for spermatogenesis. It requires FSH and testosterone. So in the end, it requires FSH and testosterone. Both will act on Sertoli cells, and Sertoli cell will support spermatogenesis. Male factor. Now, coming to infertility, male factor alone contributes to 30% of infertility cases, and people who undergo assisted reproduction, IVF, in them 40 to 50% of the males have some contribution from male is there in their infertility. Combination of male and female. So female factor is there. A combination of male factor is also there. So male factor is important when it comes to infertility. Etiologies are classified as pre-testicular, testicular, post-testicular, just like in women. This chapter is for those who are thorough with female reproductive physiology. In females, what happens? You have something called Coleman syndrome, where FSH is low, LH is low, and that is why she doesn't ovulate and it results in anovulation. So what do? You give exogenous LH, FSH, and they start. Or no, you can't give. Coleman, what happens? It is GnRH deficiency. So you can even give pulsatile GnRH and they'll start ovulating. So similarly, pre-testicular means the problem is at hypothalamus or pituitary. Coleman is a problem at hypothalamus or pituitary. It is a problem at the level of hypothalamus. What happens in Coleman syndrome? GnRH deficiency with anosmia. Because GnRH is deficient, pituitary will not secrete FSH and LH, and that is why you need FSH LH for spermatogenesis, so the person will have azoospermia. So what will be the hallmark of hypogonadotropic hypogonadism? Whether it is hypothalamic or whether it is pituitary, why don't we check for GnRH levels? Because it is pulsatile and the levels fluctuate a lot. And we don't have a reference range for GnRH. So we never test for GnRH. We test for FSH LH. FSH first. FSH plus testosterone, total testosterone is good enough. If both of them are low, compared to the reference ranges, then you know that it is hypogonadotropic hypogonadism, and the treatment is simply giving FSH with LH, and they resume spermatogenesis. The testicles resume spermatogenesis when you give FSH and LH in them. Right, that's pre-testicular. The hallmark is low FSH, low testosterone. There can be testicular. The testicles can also be small if they have long-standing hypogonadotropic hypogonadism. And testicular is when testicles are affected, like there was mumps or orchitis, because of which the testicles have post-infection inflammation and they have failed to resume spermatogenesis, or there is injury, or there is cryptorchidism, because of which the spermatogenesis has decreased. Testosterone level may also start to decrease. When testosterone decreases, what will happen? FSH will start to rise. So that's called hypergonadotropic hypogonadism in females. And in males, we don't use this word. We don't use this term. Because there are a lot of patients that you will come across when you see male infertility, a lot of cases of male infertility you will see, where you will see that there is testicular failure, there is no obstruction, FSH, LH levels are in normal ranges, and a biopsy is done and they find out that there is no spermatogenesis. So these are the cases of testicular failures or testicular azoospermia, where FSH is in the normal ranges and there is no signs of obstruction also. So there are a percentage of testicular azoospermia cases where FSH will be in the normal ranges. So this is slight difference that I want you to know from female. Whereas in females, if they fail to ovulate because of ovarian failure, the first sign, not the first sign, but a very specific sign is rise in FSH. The first sign will be fallen AMH and fallen inhibin. So similar to that zone, where spermatogenesis has got affected, but not so affected that FSH has started to rise. If FSH is high, testicles are small, this is a very severe case of testicular azoospermia, severe case of failure, where the chance of recovery of spermatozoa from the testicles is very low. So this is that phase where it's early. It's a recent onset spermatogenesis failure where the hormone levels are normal. So this is important point. Post-testicular, which means obstructive pathology, vas deferens is absent, or vas deferens is obstructed, or ejaculatory duct is obstructed, or there is ejaculatory dysfunction, as in the person is having an ejaculation, erectile dysfunction, or the urethral valve, as I told you, doesn't close at the time of ejaculation. So that is called retrograde ejaculation. Those are ejaculatory dysfunctions. In these conditions, what will happen to the hormone levels? They'll be in normal ranges. So normal ranges of FSH and testosterone is seen in post-testicular causes. The causes of male infertility where sperm motility is affected, like Cartagener's syndrome, or globozoospermia. They're also counted as they're also considered under post-testicular causes of male infertility. So three things: ejaculatory dysfunctions, obstructive causes of the male reproductive system, and sperm defects in sperm motility are also post-testicular. Spermatogenesis is there, but the sperm are not motile. Here, hormone levels will be normal. In severe testicular failure, FSH will be high, testosterone will be low, but early onset or recent onset testicular failure, or a lot of cases of testicular failure, FSH, LH may be in the normal ranges. Pre-testicular, the hallmark is low FSH, low LH, and low testosterone. Right, so hormone levels will help you differentiate between a few conditions. When they are abnormal, they are useful. When they're normal, they're useful only in obstructive cases, but normal levels really don't tell us. In a person with azoospermia, if the FSH is very low, it is hypocorrectable by medical management. If the FSH is very high, it is hypergonadotropic hypogonadism, testicles have failed, and nothing, we can't do much about this case. We might have to do microtestes, surgical sperm retrievals, but that's a bad prognosis thing. But then there are cases where the hormone levels are normal. Those cases can be obstructive, or those cases can be testicular. Right, that's why FSH, as I discussed about the question, FSH is not the answer to that question. Etiologies of male infertility. Now, that was just an overview. Now I'm giving you a small list. Pretesticular can be hypothalamus and pituitary. So how is the flowchart? Hypothalamus secretes GnRH. GnRH goes and acts on the pituitary gonadotropes. Gonadotropes secrete FSH, LH. So pituitary conditions will also lead to pituitary conditions like adenomas, prolactinomas, or as I told you about exogenous systemic testosterone, because that will cause decrease in FSH, LH. Testicular mammsarcitis, cryptorchidism is what? Undescended testis. The temperature is not maintained and spermatogenesis fails. Y chromosome microdeletion, big discussion can be there on this, but it's not important, I think, for NEET PG. And then trauma. There are post-testicular causes like obstruction, which results from CBAVD, CFTR gene mutations, result in various symptoms. What happens in CFTR is secretions get collected, dried, inspissated, and as a result, multi-organ dysfunctions result. Like there'll be problems in the lungs and pancreatic secretions, and the CFTR gene, the CFTR protein is also required for development of male reproductive system. And as a result, this gene mutation also results in bilateral absence of vas deferens. So that becomes an obstructive cause of azoospermia. Spermatogenesis is normal in the testicles. Hormone levels, that is why, are normal. But sperm is not entering into the urethra for ejaculation. Young syndrome, again, something to do with movement of the cilia so that mucus secretions get plugged. And here bilateral vas deferens are not absent. Here the vas or the entire pathway is obstructed. So this is also obstructive pathology. And then there is ejaculatory duct obstructions. Here also CFTR gene mutations may be present, infections, and disorders of sperm motility like cartilaginous syndrome. Globozoospermia is where the sperm, they lack the acrosomal cap that's there on the spermatozoa, and as a result of which they're not able to fertilize the oocyte. Ejaculatory dysfunctions and retrograde ejaculations. These are post-testicular. All of these conditions, hormone levels will be normal. Male partner evaluation is all of these things. History, see, history is easy to say, but you understand how to take history, what history to take, what positive, what negative, after you understand the whole chapter. So I'm not talking about history right now. A few things in history I already told you. We'll be talking about semen analysis, from which you get questions, and then the rest of the things. Semen analysis, what all we see in semen analysis: sperm count, semen volume, sperm count, and sperm concentration. I'll tell you what the difference is. Morphology, volume, morphology, motility, and other parameters like viscosity, pH, vitality, biochemistry like fructose is present or not present. Now, this is the table that you will get if you see WHO article of 2021 on the reference manual that they say. And this is a complicated table. What you're supposed to see here is these parameters. And the fifth centile, the lower limit of normal. How did they come to this table? They took 3,000 to 4,000 people, couples who were starting out to try to conceive, and they conceived at the end of 1 year. So all of these people are fertile. And in this, they saw the distribution. They saw that fifth centile, that 95% of the people had a semen volume of more than 1.4 ml. So this is the lower limit. The last 5% only 5% of the fertile people will have a semen volume less than 1.4. That is how we derive, and we call anything less than the fifth centile abnormal. So you're supposed to remember this part and this part of the table. I've simplified it for you to remember, to memorize. Semen volume, fifth centile is 1.4. Anything less than this is abnormal. Sperm concentration is million per ml. This is not million per ml. This is total in millions. This is million per ml. 16 million per ml of semen volume. Total sperm number is, if it is 2 ml, and the count is 20 million per ml, the total number will be 20 into 240. Total sperm number less than 39 is abnormal. Total motility is progressive. Earlier it was grade 1, grade 2, grade 3 motility. That has been removed from WHO 2010 article. This one says only 2 types of motilities: progressive, non-progressive, and non-motile. So we are bothered about total motility and progressive motility. Total motility is motile spermatozoa, which includes progressive as well as non-progressive, just being motile in the same place. That should be 42 and progressive motility should be 30%. Vitality is, see, if 42 is total motility, which means out of 100, 42 spermatozoa are showing motility, which means not 68, 58 spermatozoa are immotile sitting there. Now you don't know whether those 58 are alive or dead. The motile ones are definitely alive, but out of the 58, some may be alive, some may be dead. So when the motility is decreased, we do the vitality to see if all the remaining spermatozoa are dead or not. So vitality in total should be 54%. Out of 100 spermatozoa, 54 should be alive at least. Normal forms 4%. If you see a semen report and they quote a normal form percentage of 85%, you should understand that this person doesn't know how to do semen analysis, because the morphology has to be checked by Kruger's criteria, strict Kruger's criteria or Tigerberg criteria, same criteria these are. This name is more commonly used. They are similar. Two different people have come up with these criteria, Kruger's criteria or strict Kruger's criteria. With the use of that, you'll only get 4% normal forms. And if they're saying 85%, they haven't seen it properly. Less than 4% is abnormal. And this is 95% confidence limit of this central value, fifth centile value. You need not remember this, but at least this is the values that you have to remember. Now, I've come across a lot of terms like hypospermia, oligozoospermia, stheno, necro, terato. What are these terms? How to define in terms of semen analysis? This is how you define them. If the semen volume is less than the fifth centile of the reference ranges, we call it hypospermia or low volume semen. If the concentration and count are low, you call it oligozoospermia, less number of spermatozoa. Motility is low, asthenozoospermia. Vitality is poor. A lot of spermatozoa are dead. You call it necrozoospermia. Abnormal forms are more. Normal forms are less than 4%. You call teratozoospermia. So these are the terms to understand. And then there are other terms like oats. You'll hear this commonly in fertility clinics. Oligo, astheno, teratozoospermia. All the three abnormalities of number, motility, and vitality. What is it? Terato is not vitality. Terato is morphology. Azoospermia is ejaculated semen devoid of spermatozoa. So you have, say, 2 ml of semen collected from the patient, and you saw under microscope, you couldn't see any motile, non-motile, or dead or alive, whatever kind of spermatozoa. So what will you do? You'll think it is azoospermia, but there could be traces of a few spermatozoa. So what I'll do is I'll centrifuge and I'll form a pellet. And I'll see that pellet under my microscope. So I've concentrated the cells. When I make pellet, I've concentrated all the cells. So I'll check all the cells again. And among the cells, if I still don't find any spermatozoa, I call it azoospermia. If I find spermatozoa in that pellet which contains cells after centrifugation, then I call it cryptozoospermia. That is why the definition of azoospermia is no sperm identified in centrifuged pellet. 3000 rotations, 2 separate samples are taken. G is a unit of centrifugation. 2 separate samples, 2 weeks apart. You have centrifuged, you have checked the pellet. Then when you see no spermatozoa, then you call it azoospermia. And what is cryptozoospermia? Cryptozoospermia is absence of sperm in ejaculated semen by microscopic examination. But when you centrifuge, you find a few spermatozoa. So this is a type of extreme oligozoospermia. And what is severe oligozoospermia? When the count is less than 5 million per ml. The concentration is less than 5 million per ml. Now, when to repeat? Now, you did a semen analysis and you found out that it was abnormal. There can be 2 kinds of abnormalities. One is just borderline abnormality, that the count is 12 million per ml. The total count is maybe 30 million per ml. Motility is okay. So few parameters are here and there, but they're close to the reference limit. So what do you do in these cases? These cases can result from transient events like fever or a few factors that can affect spermatogenesis, the toxins that are there in the environment nowadays, or some other illness which happened recently. So what we do, each cycle of spermatogenesis takes 3 months. So you wait for the other cycle. The severity is not much. And you're not going to do IUI, IVF, ICSI for borderline abnormalities. So you wait for months and repeat an analysis. But suppose if there's a severe abnormality, severe oligozoospermia or azoospermia, you need to decide about the management. You need to decide about hormonal testing to be done. So in those cases, we repeat at 2 weeks. So when to repeat a semen analysis in case of abnormality depends on how abnormal the report is. And if it is normal, you don't have to repeat. So infertile couple comes to me, I decide to do a semen analysis. It is normal, I will not repeat. It is abnormal, I will decide when I want to repeat before giving the final diagnosis. If they're normal, one test is good. If they're abnormal, you need 2 tests. And further andrological investigation. When to repeat? Earliest 2 weeks, latest 3 months. You know why 3 months? Because 3 months is the time spermatogenesis takes. So that transient effect to go and the spermatogenesis to resume, you need to see to be able to see the result, you need 3 months gap. 2 weeks. Why 2 weeks in severe abnormalities? Because the couple is anxious. It is azoospermia. We need to decide treatment faster. It's not that if today there is azoospermia, there'll be a miracle in the next cycle and the other 3 months later and the person will have a full count. That's not going to happen. Or if it was an artifact, it was wrong, because it was a wrong report, then also 2 weeks later you get to know that that was a wrong report and now we have a better report. Right? Improper reporting or an actual abnormality, repeat test in 2 weeks. Mild abnormality, repeat in 3 weeks, 3 months. So we talked about semen analysis. Now male physical examination. Now, this is interesting in male reproductive evaluation, that first you do semen analysis. Always history is followed by physical examination for all our exams. But here, luckily, you take history, you do semen analysis. If semen analysis is normal, forget about male physical examination. We don't need to examine the genitalia and secondary sexual characteristics. All we are bothered about is the semen. The semen is good, you do your management yourself. We just need to check your fertility. For all other things, you see other doctors. So physical examination, male is not primarily our patient. Our patient is the female who has to carry the pregnancy. So as long as the male partner semen is normal, I'm not going to touch the male. But if semen analysis is abnormal, the next is hormonal evaluation as well as a physical examination. What I do is I send them to urologist if I believe that a andrology examination is required. But in the exam, you're not going to do that. No, you have to do male physical examination, hormonal evaluation. So both of these things in case of abnormal semen analysis report. Imaging plus minus. Very rarely you will need to do imaging in male reproductive system, genetic evaluation, testicular biopsy, all those things we'll be talking about. So currently we're talking about male physical examination very quickly. If semen parameters are abnormal, only then. So this is the place where we do investigation first and physical examination later. What you will see, secondary sexual characteristics and genitalia. When will this be problematic? Hypogonadotropic hypogonadism. In testicular failures, it will be very, very late when secondary sexual characteristics get affected. It will be severe testicular deficiency that they'll lose their facial hair and all. Otherwise, loss of facial hair does not really correlate with testosterone in testicular failures. Scrotum exam for the testicles. You can do vas deferens and epididymis. You can do a scrotal examination to check for these. How do you examine the testicle? The scrotum should be palpated with patient in standing position. Testicular size and consistency should be noted. How do you note the testicular size? What is normal testicular volume? We use orchidometer. Now, orchidometer is a funny instrument or whatever equipment. It's not like a scale or it's not something that would measure volume. I'll show you a picture. It's funny indeed. Mean volume of 20 is considered normal. Consistency, firm, normal, hard, whatever. If one testis is impalpable, look for undescended testis. Groin examination should be done. Vas deferens, you can palpate the spermatic duct to see if vas deferens are there or not there. Epididymal abnormalities can also be judged on examination. And then the next is varicose veins. These are just enumerating. Once you know the etiologies, once you know what all you can see, you'll be able to write such answers. But otherwise for MCQs, these are not important. Penile abnormalities, rectal. So basically for Viva, if you have a urology or andrology Viva, then these things are important. Otherwise, there's hardly ever a situation that we have to do the male examination or orchidometer. This is what it looks like. Balls to measure the size of balls. They just look like this. And they've written the volumes here. And you have to see this matches this size. So it is this volume. Anyways, that was funny. So we have done Semen analysis, male physical examination. Now we'll do hormonal evaluation and then imaging and all those things. So let's talk of hormonal evaluation. We've already discussed a lot. Pre-testicular hallmark is low FSH, low LH, and low testosterone. Testicular FSH may be normal. If it is high, it is severe testicular failure. Post-testicular hormone levels will be normal. This is the same table, same thing. Testicular hypo, it may be called hypo. FSH may be high. If it is high, it is severe testicular failure. The chance of retrieval of sperm from testicles is very low. Testosterone will be low in both the cases. Can be normal also. Post-testicular, everything will be normal. What are the reference ranges? Total testosterone 250 to 1000. Free testosterone. Generally, the assays, the laboratories were not very accurate in measuring free testosterone, so it's better to order total testosterone. Free testosterone is estimated using a lot of indirect tests. So if you want to order one thing from your lab, you order total testosterone, FSH, LH, Pro. If testosterone is low, FSH is low, then we move on to the next tests, LH and prolactin and TE ratio. TE ratio is not very important for you. Testosterone to estradiol ratio, not important. It is important in deciding the management. It doesn't tell you about the etiology of male infertility. So not important. FSH, the range. Now this is the range in laboratories. They'll give you, this is lower limit, this is upper limit. But what is the FSH to diagnose testicular failure is 7.6. If it is more than 7.6 and the person has azoospermia, it is likely that there is testicular failure. You don't need to do any other tests. So first test, so if there is severe semen abnormality like oats or cryptozoospermia or severe oligozoospermia, you have to do these tests. FSH and total testosterone test has to be done in all the cases. If these are abnormal, then I need to know if this is low, both of them are low. I need to know whether it is hypogonadotropic hypogonadism or not. So I will do LH levels. I'll also do prolactin and TSH because prolactin and TSH abnormalities, just like in women, they may also lead to hypogonadotropic hypogonadism in men. LH and prolactin, TSH not as important, sorry for that. So LH and prolactin will be done if these are abnormal. If these are low, basically. If these are high, you know it is not hormonal, it is the testicles that have failed. If these are low, you know it is hormonal deficiency. Prolactin is also indicated in hypo. That is what I said, no? Low testosterone, low FSH, decreased libido. You do prolactins also. Prolactin can also cause hypogonadotropic hypogonadism. That physiology, pathology is again a topic of another big discussion. Low FSH, LH testosterone, low sperm concentrations, we are dealing with hypogonadotropic hypogonadism, hypothalamic or pituitary causes. Elevated FSH indicates severely impaired spermatogenesis, so testicular failure it indicates. But normal levels can be testicular failure or can be obstructive. If testicular failure impairs the spermatogenesis only and not the endocrine function, testosterone, FSH, LH levels may be within normal limits. This is from Gardner's. So this distinction is easy. This distinction between testicular and post-testicular is difficult. So we've talked about hormonal evaluation. Now I think we'll be talking about testicular biopsy. When do you need testicular biopsy? Testicular biopsy aim is, it is done in cases of azoospermia. Its aim is not only diagnosis, its aim is also to procure spermatozoa for ICSI. Now somebody has azoospermia and they want their own genetic child. What will you tell them? That we'll not be able to give you your genetic child. That's not how we can say. We'll tell them that we'll try to surgically retrieve spermatozoa from your testicles because there could still be islands of spermatogenesis in your testicles. There could be seminiferous tubules where spermatogenesis is still present. Now, if the FSH levels are very high, you counsel for a poor prognosis that if FSH is very high, we know that the spermatogenesis is severely affected. If FSH is in the normal ranges and you know it is testicular failure, then you can give them hopes that we could get spermatozoa. So most important aim of testicular biopsy is surgical sperm retrieval. The procedures that we do are called TISA, TESI. These are procedures for sperm biopsy, for testicular biopsy, where what we do is whatever spermatozoa are there, we freeze them or cryopreserve them. And So what will the embryologists do? They'll take the spermatozoa and they'll freeze them. And the rest of the tissues that you have got, the seminiferous tubules, you'll send for HPE. And at the HPE, they'll tell you that there is either maturation arrest as in you'll see the seminiferous tubules, you'll see Sertoli cells, and you will see spermatozoa, spermatids and no spermatozoa. So you know that there is maturation arrest. Or the worst form of failure of spermatogenesis is Sertoli cell only syndrome. There is seminiferous tubules, and all you see is seminiferous tubules. No spermatozoa or spermatids are seen. So this is completely failed spermatogenesis. So the HPE can be anywhere between this and this, or it could be normal spermatogenesis. You're seeing lumen full of spermatozoa. This will tell you that this is obstructive, and there you can easily retrieve spermatozoa. You don't even need to do TESI, you can do PISA, you can collect it from epididymis also. So the diagnostic test to differentiate obstructive and non-obstructive or testicular azoospermia is testicular biopsy. But if you see guidelines, they'll say if you want to do testicular biopsy for diagnosis, counsel the couple that if I find spermatozoa, I will freeze them. Before the procedure only, you tell them that if I find spermatozoa, this is not only diagnostic, this is also therapeutic for you. If we find spermatozoa, we'll freeze it. Because if you've done one biopsy just for diagnosis, you found spermatozoa, you threw them away. Next time you try to do biopsy, you might not find spermatozoa. So you freeze. So those are the two aims: definitive diagnosis to detect spermatogenesis, to give a histopathology report whether spermatogenesis is present, which will be there in obstructive causes, whether there is maturation arrest or Sertoli cell only syndrome. It also facilitates sperm recovery for if you're doing IVF in the same cycle. If you've already counseled that we'll do IVF only, then you use the spermatozoa for IVF ICSI or you freeze. That is the usual case. We start evaluating. We tell them, let's evaluate, let's see your biopsy. If spermatozoa are there, we'll freeze and then we'll stimulate your wife, we'll collect her oocytes and we'll do IVF, right? These are the aims. What are the indications according to guidelines? Diagnostic biopsy or aspiration, FNAC or biopsy/biopsy is primarily indicated if there is uncertainty whether the patient has obstructive or non-obstructive. So which is the diagnostic test between obstructive and non-obstructive? It is testicular biopsy. But this is an example. Normal semen volume is there. Normal or near normal testicular volume is there. Vas deferens is there. So you know that doesn't look like it's not outrightly obstructive and it is not outrightly testicular failure. We don't know what it is. The hormone levels are normal. Everything looks normal. Then I do a testicular biopsy. Near normal FSH, serum FSH concentration does not always guarantee normal spermatogenesis. So in those cases, you take the patient for testicular biopsy, but do it at an IVF or reproductive medicine center so that you are able to freeze the spermatozoa. Don't just take a biopsy under ultrasound and FNAC under ultrasound and send it for histopathology. If possible, biopsy or aspirate is performed with additional ability to examine for sperm, their viability, vitality, and cryopreserve it. That's the rule. So why I'm telling you so much about testicular biopsy, because that is the answer to the question that a lot of people have answered incorrectly in the recalls. Testicular biopsy is not routinely required for diagnosis. Just for diagnostic purpose, if you're having a doubt, you don't go ahead with it. Most of the cases, you'll not need it because if FSH is very low, you know the diagnosis. If FSH is very high, you know the diagnosis. So FSH is very low, don't do biopsy. FSH is very high, don't do a biopsy. If outright obstruction is there, like bilateral absence of vas deferens is there, don't do biopsy for diagnosis. For management, where we do, for retrieval, which cases we do testicular biopsies or TESI or TISA, we'll discuss in the management class. Azoospermia with markedly elevated FSH is there, you don't need it. No, azoospermia with obstruction is there, you will not do it. Or azoospermia with very little FSH, very low FSH, you will not do. Let's talk of imaging. Imaging is hardly ever needed for male reproductive system examination because we already measured the size of the testis with those orchidometer. And for vas deferens, you can palpate the spermatic cord. For ejaculatory duct obstruction, you might need sonography. So we'll see what is the role of imaging. Ultrasonography is indicated only in a minority of infertile male patients. Those male patients who have obstructive pathology, where you believe that doing a surgery might help, might reverse the obstruction, and the person may become fertile again. In those cases, you will do an ultrasound. which is very rare. Most of the cases can be identified, or whatever you have to gain from physical examination, you will gain, and ultrasound will not additionally help you much. Even varicoceles are clinically important only when they're palpable clinically. Varicoceles diagnosed on ultrasound have not been associated with spermatogenesis abnormalities. So you can examine for varicoceles, spermatoceles, absence of vas deferens, epididymal induration, and testicular masses. Everything you can examine on physical examination. And if you don't find anything, don't do an ultrasound. If you find anything abnormal, like you find a testicular mass, you will obviously do a scrotal USG. So two imagings that we can do is scrotal USG and transrectal ultrasonography. Like we have transvaginal sonography for females, we have transrectal in both males and females. So transrectal will tell you about the ejaculatory ducts, which is close to the prostate. Whether there is ejaculatory duct obstruction, sometimes ejaculatory duct dilatation and all can be seen. Scrotal ultrasonography or cryptorchid testis, if you've seen. So if you find anything on examination of a person with abnormal semen analysis reports, then all of this is going to follow only when semen analysis is abnormal. If semen analysis is normal, don't do all this, even if you're an andrologist. Scrotal ultrasound can identify occult varicocele, CBAD. CBAVD may be diagnosed clinically. If you want to do ultrasound, you may do it. TRUS helps ejaculatory duct obstruction identification. So whenever there is testicular failure, you can see the size of testicles on oxidometer. You don't need a scrotal ultrasound. But whenever there is an obstructive pathology, if the patient wants to know what is the reason, you can advise a transrectal ultrasonography to see ejaculatory duct obstruction. One of the findings in semen analysis of obstruction is low semen volume. So if there is low semen volume and you're suspecting obstruction, then you can do TRUS, but generally not very required in all the cases. So we talked about this, and this. And now I think genetic evaluation. When do we need genetic evaluation? Pre-testicular or hypo, what are the causes? Genetic in 1/3. Coleman syndrome is genetic. Which mutation is responsible for Coleman syndrome? Col gene. A lot of mutations, many mutations are there. How is the inheritance? Can be autosomal dominant, can be autosomal recessive, can be X-linked, so various ways of transmission, and it is also affected by environmental. So we cannot have one test for Coleman syndrome, and we cannot do one kind of counseling for Coleman syndrome. So we don't test for Coleman syndrome. If it is a case of hypogonadotropic hypogonadism because of Coleman syndrome, they're only affected by anosmia and they only have low FSH level, because of which they have infertility. So you just treat the infertility and forget about the rest. So don't do genetic testing if you're suspecting Coleman syndrome. Testicular causes can be chromosomal or can be genetic. Genetic is Y chromosome microdeletion. So these two tests can be done. If there is severe oligozoospermia or azoospermia, Coleman syndrome testing is not there, not advised. It is for research purposes. But what test we can do is a karyotype with testing for my Y chromosome microdeletions. These are expensive tests, but karyotype is acceptable. For obstructive causes, which is the genetic condition causing obstructive azoospermia? It is CFTR gene mutation causing CBAVD. What happens in obstructive causes is you're going to take spermatozoa from epididymis. You're going to aspirate semen from epididymis, and you're going to use those spermatozoa for IVF or ICSI to give the couple offsprings. But what happens is there is CFTR gene mutation. This is a severe condition. It can amplify in the next generation, but it is autosomal recessive. So before using this male partner spermatozoa by PISA, you always have to check the female, just like thalassemias, you have to check the female partner for CFTR gene mutations. If CFTR gene mutations are negative, only then you collect spermatozoa. If they're positive, it's a different story. The management is still there, but we will see, but we can't see it right now. I said management is for the next class. So CFTR gene mutation, in short, I've told you that. So if obstructive cause is there, especially if vas deferens is absent or ejaculatory duct is obstructed, you will test for CFTR gene mutation. So these are the three genetic testings that we do. If it is non-obstructive azoospermia or severe oligozoospermia, which is non-obstructive, numeric and structural chromosomal aberrations can be there, Y chromosome microdeletions can be there. And if it is obstructive cause, we are bothered about CFTR gene mutations. So what are the recommendations? Karyotype and Y chromosome microdeletion should be done if there is azoospermia or severe oligospermia with elevated FSH, testicular atrophy, or on testicular biopsy of diagnosed spermatogenesis failure. Simple. If vas deferens is absent, EDO is there, you do CFTR gene mutation testing. That is when indicated. So when indicated, always do CFTR testing and karyotyping. Obstructive CFTR, non-obstructive, do a karyotype once, because this will have implication on the general health also, both of these tests. You need to look after the other conditions that result from karyotype, as in some people with Klinefelter syndrome will have azoospermia. They are raised as normal males, and then at the time of when they come with infertility only, then you realize that they were Klinefelter syndrome. So they need to know that they're Klinefelter syndrome, and we need to take care of the other features of Klinefelters. That is why karyotyping is important. And CFTR gene mutation obviously is important if they've come for fertility. Y chromosome microdeletion may or may not be done. It is optional. It is expensive. Result doesn't alter the management. Y chromosome microdeletion, till now, we just know that it affects the fertility only, doesn't affect anything else as far as we know right now. So you may skip it because it is expensive. The only thing, for counseling, it will help, as in it will tell you the etiology. The couple will know the etiology of male infertility, and you can tell them that if it's a boy, after your IVF, when I use your testicular spermatozoa, then the boy will definitely have this Y chromosome microdeletion, which means again, the next generation will also need surgical sperm retrieval and IVF. Now, there's another test. We discussed about all the other tests. There is also one more interesting test, post-ejaculatory urine analysis. So, as I told you, during ejaculation, this closes so that semen is ejaculated outside into the female reproductive tract. But sometimes the bladder neck doesn't close, and all of the semen instead enters here into the bladder. And in the ejaculate, there is just a little bit of semen with few spermatozoa or no spermatozoa. So this can result in severe oligospermia, hypospermia, as well as azoospermia. In that case, is what we do if we're suspecting this, what we do is after the man has ejaculated, we ask them to pass urine, and we collect that urine, centrifuge the urine, and we see if spermatozoa, a lot of spermatozoa are there inside the urine, that is called retrograde ejaculation. To exclude retrograde ejaculation, post-ejaculatory urine analysis, when do you do? When you see features of obstructive pathology, like this is a differential for obstructive azoospermia, retrograde ejaculation. They'll have low volume, normal FSH, normal testicular volume. So before labeling it obstructive, you can look for post-ejaculatory urine analysis with spermatozoa inside. Because then this will not require surgical sperm retrieval. This will just require isolation of spermatozoa from the urine. If there is a diagnosis of hypogonadism, there is a diagnosis of CBAVD, there is a diagnosis of testicular failure, then don't do this. But otherwise, when you're suspecting obstructive cause, then you do this. Now coming to the algorithm. Now, what I told you initially, we have to go back to the slides where I said that the semen volume comes from seminal vesicles. What else comes from seminal vesicles is the pH. The pH rises because the secretions are alkaline. What else comes? Fructose comes from the seminal vesicles. So let's not go back because I've already told you seminal vesicles add volume to the semen, pH of the semen, and fructose. So if there is azoospermia or oligospermia along with low semen volume, low fructose, and low pH, acidity is more, then you think of obstructive cause, you think of CBAVD, you think possibly that the seminal vesicles are not draining into the urethra or draining. As per the algorithm of azoospermia. So you have a person with azoospermia, no spermatozoa in the semen. What do you do next? You know what you do next, the physical examination and all those things. But first you see the semen report. How is the semen volume? Apart from azoospermia, what are the other parameters? So we see the first, before ordering FSH, LH or whatever, before deciding what to order, we will see the entire report. We'll see the volume, is there hypospermia? We'll see the pH. We'll see the fructose. If all of this is low volume, low pH, low fructose, then it could possibly possibly be obstructive pathology, for which we will see the next slide. So from the semen analysis report, we can get whether there's a likelihood of obstructive pathology, which we will see the next slide for. But all cases of azoospermia, we know from the guidelines that we have to do a hormonal evaluation. So even if you're thinking of obstructive pathology, do a hormonal evaluation, doesn't harm, doesn't cost a lot also. So do a FSH test and do total testosterone levels in all the cases. If FSH LH, we have seen the whole story. If FSH LH is low, then we will do LH estradiol prolactin. Estradiol because we want to know the TE ratio because that will help us decide the management in a few cases. Low FSH, low testosterone, low volume semen. So low volume semen is there here also in pretesticular or hypogonadotropic hypogonadism. That is why even if the picture looks like obstructive, this is not fully diagnostic of obstructive. This is just indicative of obstructive, which we have to evaluate further. So hormonal test is a must in all the cases. And if this is what you get after hormonal test, low volume, low testosterone, low FSH, the other things don't matter now. Whatever the pH is, whatever the fructose is, because fructose is not a very sensitive, very specific test. Sometimes there can be a lot of artifacts which can affect the fructose. So forget about the other things. And if you have this picture, it is pretesticular, it is hypogonadotropic hypogonadism. This is a good diagnosis to have because this can be corrected by giving HCG plus FSH. And they can have their own natural pregnancies. If it is high FSH, low testosterone, it indicates abnormality in spermatogenesis. Or Y chromosome microdeletion, it should have come here. And in a case of azoospermia, if FSH is normal, testosterone is normal, persistent normal semen volume is there, or maybe low sometimes, but there is azoospermia. And you really don't know what the etiology is, whether it is obstructive or it is testicular failure. In those cases, you do a testicular biopsy, but take a pre-procedure consent, pre-procedure counseling should be done, that if we find spermatozoa, we'll freeze it for ICSI, right? And then you do karyotype in these people. If you see spermatogenesis failure. And with suspected non-obstructive azoospermia due to elevated FSH, testicular biopsy is not indicated. We already saw that if FSH is high, FSH is low, or obstruction is evident, a biopsy is not required for diagnosis. Now I was talking about this next slide. If there is azoospermia with low semen volume, low pH, low fructose, and your hormone levels are normal, now you need to rule out obstruction first. So see the semen volume and pH we are seeing low semen volume, low pH, lower absent fructose. PEU is what? Post-ejaculatory urine sample. You take a post-ejaculatory urine sample, you find significant spermatozoa. Your diagnosis is retrograde ejaculation. Here what you do is, next time you call the female when she's ovulating at that time, we collect spermatozoa from the urine. We alkalinize the urine. There's a whole procedure done for that, and we do intrauterine insemination. So in short, the treatment is IUI for retrograde ejaculation, if you can't medically correct it. There are also medicines for this. Again, management part is different. Now, post-ejaculatory urine you tested, but it had no spermatozoa. This means, so what did I tell you? That if you have such report, you have two differentials. One is retrograde ejaculation and the other is a proper obstruction. So now we need to rule out a proper obstruction. So post-ejaculatory urine has no spermatozoa. So what I'll do is I'll palpate the vas. If vas is not palpable, it is CBAVD. We'll do CFTR gene mutation testing. If vas is palpable, now we don't know what is the etiology. It could be ejaculatory duct obstruction. So in that case, we do a transrectal ultrasonography. Ejaculatory duct is dilated, it is ejaculatory duct obstruction. Some TURID is the management of ejaculatory duct obstruction. Some cases you don't find any etiology and you have to go ahead with a biopsy. If nothing else is there, again, you'll have to go ahead with biopsy only. Yeah, see, if everything is normal, what they have done, normal spermatogenesis on biopsy. So the next step when everything is normal is testicular biopsy only. And a lot of cases, everything will be normal and you will not come to. So it's not so easy to find out the etiology in all cases of azoospermia. In fact, when you work at a fertility center, you will realize that a lot of cases of azoospermia are not even diagnosed and they undergo testicular biopsy directly to collect the spermatozoa. So this was the question. A couple presents to infertility clinic with normal HSG. Semen analysis shows azoospermia, which of the following test is the best to differentiate between testicular and obstructive? I don't know if vas deferens obstruction, vas deferens what was there or not, because then you'll just palpate, no. But that was not the option. Luckily, it's not testosterone, it's not FSH, because we've repeatedly have said that there can be testicular failure, testicular azoospermia with normal FSH. So FNAC of testis, testicular biopsy or testicular aspiration. This is your answer. There was another interesting question. Seminal vesicles and vas deferens would be bilateral absent congenitally. Which are the following conditions? We know it. Cystic fibrosis, CFTR gene mutation results in cystic fibrosis as well as bilateral absence of vas deferens. There are a few more interesting questions on male infertility in the NEET PG exams, which we'll discuss later.